Hello and welcome to Astrology's Medicine. Today, in this video of Respiratory Medicine Series, we shall be continuing our talk on dyspnea. So, the contents of this video are general outline about the management and diagnosis of dyspnea, history taking, red flag pointers in dyspnea, general tips about the history and red flag pointers, and ultimately concluding the video by summary. So, let's start with the general outline. So, here, if the patient comes to you with a primary episode, that is the first episode of dyspnea experienced by the patient, or the patient has a worsening condition of dyspnea. So, in such condition, we have to ask a question that is either the patient had a known prior condition causing dyspnea or not. So, if the patient had some known prior condition which caused dyspnea, and the condition has also worsened along with the dyspnea, then we have to treat the condition because the condition, that is the known prior condition, is the most likely cause for dyspnea in the present episode. Whereas if the answer to the question that is, has the condition worsened, is no, then we have to look for another cause and treat it because in such condition, the known prior conditions are rare for causing the present episode of dyspnea. So after that, if there is no known prior conditions, then we have to ask a question that is the patient's condition severe? And the answer to this question might be either yes or no, and it is usually seen by eliciting the vital signs. So if the vital signs are stable, then we have to consider that the patient is not severe, and if it's not stable, then we have to consider that the patient is severe. However, this might vary according to the condition. So if it's a yes, then we have to provide the supportive treatment first, followed by the by the diagnosis for the cause, and ultimately treating the cause. However, if the answer to the question that is the patient severe, is no, then we have to straight on look for the condition. That is history taking, examination, imaging, and laboratory investigation, and treat the cause. So after that, we'll be talking on history taking. So the most important question that we'll be asking in history is timing. That is the onset and duration of dyspnea. So if it's from seconds to minute, then we have to suspect pneumothorax, myocardial infarction, anaphylaxis, foreign body inhalation, or pulmonary embolism. Whereas if it's from hours to days, then we have to suspect of exacerbation of pre-existing conditions such as COPD, asthma, congestive cardiac failure, or pleural effusion, pulmonary edema, or metabolic conditions such as acidosis or infections. Now, if the timing is usually chronic, that is weeks or longer, then we have to suspect for some miscellaneous conditions as we had classified earlier. That is anemia, neoplasia, obesity, tuberculosis, COPD, interstitial lung disease, or pulmonary fibrosis. So the next question that we'll be asking in history is quality. So what's the quality of dyspnea? As we have already mentioned in the mechanism of dyspnea, that the quality of dyspnea might be distinct based on the experience a patient has or based on the conditions the patient is in. However, there are a few distinct quality, that is air hunger, chest tightness, or both, based on some common findings. So if there's presence of chest tightness, then we have to think about the pulmonary and vascular conditions, or also sometimes chest wall and pleural condition. But most of the time, the chest wall and pleural conditions present with air hunger. Now, if there's air hunger, then we have to specifically focus on the miscellaneous condition, that is about the anemia, neoplasia, infections, and such conditions, along with the chest wall and pleural conditions. Whereas if the presentation is both, that is both chest tightness and air hunger, then we have to think about the cardiac conditions such as congestive cardiac failure, myocardial infarction, etc. So the next question we'll be asking about is effect of position. So if the patient has orthopnea, that is the patient feels comfortable for breathing while he or she is standing or sitting erect, that is orthopnea. Then in such condition, the causes might be congestive cardiac failure, obesity, or reflux associated asthma. Whereas if the patient has dysplatypnea, that is feeling comfortable to breathe while laying down or supine, and dyspnea on standing or sitting erect. Then in such condition, we have to think of left atrial myxoma or hepatopulmonary syndrome. So the next question that we'll be asking about is severity of dyspnea. Usually this is a uh, subjective scale, and we ask this to patient, and we do not use some clinical signs or any other thing to grade it, but we simply ask to the patient, how would you grade the severity of this present episode of dyspnea on a scale of 1 to 0 to 10, and he or she will grade it accordingly, and we have to record it because on the subsequent episodes of dyspnea we have to compare the severity then versus severity now. So that is an important part in the history, because it will help us to know whether the condition is worsening, whether the experience of dyspnea is worsening or not. And the next thing is we'll be asking about the daily activities performed by the individual. And it will be quite helpful if we take the history about daily activities in the terms of walking, because it will help us to grade according to the MMRC dyspnea scaling. And this MMRC dyspnea scaling is quite important because it will help us to determine whether the patient is responding to therapy or not, and what might be the outcome of the therapy and the prognosis of the treatment or the disease itself. And the next question that we'll be asking about is the infection history. So in infection history, we have to ask about pneumonia. And the point that I'd like to mention over here or focus over here is that some chronic condition, for example, obstructive lung diseases like asthma, COPD, bronchiectasis, or restrictive lung disease also sometimes. So these conditions might have acute exacerbation of dyspnea if there's presence of infection. So that needs to be asked if there's presence of infection. So we also need to ask about associated symptoms because they give us a lot of insight of what the cause might be. For example, if there's pleuritic chest pain, then we have to consider pneumothorax, pulmonary embolism, pleurisy, or pneumonia. And if there's presence of central chest pain, then we have to consider myocardial infarction, congestive cardiac failure, or large pulmonary embolism. Whereas if there's absence of chest pain, then we mostly consider the miscellaneous conditions, that is anemia or metabolic acidosis, or sometimes pulmonary edema as well. Now, in the case of a cough or wheezing, then we consider obstructive lung diseases like asthma, COPD, or a foreign body inhalation. So central chest pain correlates with the cardiac condition. Absence of chest pain correlates with miscellaneous condition, pleuritic chest pain with the pleural or chest wall conditions, and the cough or wheezing usually with the obstructive or pulmonary conditions. So after that, the questions that we'd like to ask about is on the risk factor, whether there's occupational exposures, smoking history, and allergen exposure. And the thing to be noted here is that if there is some occupational exposure causing dyspnea, then these symptoms, signs and symptoms of dyspnea are usually relieved during the weekends or during holidays and are exacerbated during the working days. Whereas in the cases of smoking, we have to mention we have to clearly report the smoking history in terms of PAC-year or PAC-year smoking history. And then if there's allergen exposure, then it might be point towards the asthmatic or some other anaphylactic reaction causing dyspnea. So the next question that we'll be asking is the previous medical or surgical history, specifically focusing on the surgical history if there's any, and then also about the drugs. So in drugs, some drugs which cause dyspnea include cytotoxic drugs used in neoplastic conditions or immunodisorders such as bleomycin, cyclophosphamide, or methotrexate, and some drugs used in cardiac conditions such as amiodarone, and anti-infective drugs such as sulfasalazine or nitrofurantoin, and chelating drugs such as penicillamine. And the most important one that is not to be missed is adrenergic nasal decongestant, because these are usually the over-the-counter drugs, and these are thought to be safe, and the patient doesn't usually suspect that and these might cause dyspnea. And these are usually missed because the patient might present to you with dyspnea, and the examination part, imaging part, or everything looks normal. However, there is presence of dyspnea. So sometimes there might be the use of adrenergic nasal decongestant that is causing dyspnea, and dyspnea will subside by the stoppage of these drugs. So these are the questions on the history of dyspnea. So now I'll be talking about the red flag pointers, which I'll be classifying on two headings. The first one being history and the second one being the examination. So in history, if there's sudden onset, then we have to point towards the factors like pneumothorax, pulmonary infarction, pulmonary embolism, or a sudden rupture of the uh, pleural cavity, or there might be myocardial infarction or ischemia or such conditions. And if there's history of ischemic heart disease, then it raises concern towards the cardiac causes of dyspnea. And if there's migration or travel, then points towards infection, asthma or allergy as it is, and then trauma or HIV infections. And if there's unexplained weight loss, then it points towards chronic condition, for example, tuberculosis or neoplasia or emphysema as well. And in examination, if there's pallor, then we have to focus on towards the anemia. And if there is cyanosis, then it might be some circulatory disorders. And if there's wheezing, then it might be some obstructive lung diseases, dyspnea at rest, usually pointing towards psychogenic conditions, and fever or some chronic conditions and fever towards infection, hypertension, tachycardia, tachypnea, altered consciousness state, and elevated JVP. Now, these all pointing towards some fatal conditions. So these are the red flag pointers for dyspnea. And after this, we're talking about the general tips. So in general tips, the first one includes that dyspnea on rest will generally point towards some lung pathology, whereas that on exertion generally points towards cardiac pathology. Now, as we had already talked in the previous video, that dyspnea is a subjective experience whose sensation might differ according to the situation patient is in. So, no specific descriptor, for example, chest tightness or air hunger, has sufficient sensitivity or specificity to be used alone in diagnosing or establishing the cause of a patient's experience. So these have to be just used as a reference point and not to be used specifically alone, and to be used with the associated signs, symptoms, some other features or risk factors and such. And we generally see that in cardiopulmonary condition, dyspnea occurs on exertion. However, in psychogenic condition or psychosocial conditions, dyspnea usually occurs at rest, and that decreases with activity. So it usually or especially point towards the psychological or psychosocial conditions of dyspnea. And it's rare in the cases of cardiopulmonary condition. So let's summarize the video. Diagnosis and treatment of dyspnea depends upon finding whether it is due to a prior known condition or not. And if it's according to a known prior condition, then treat the condition. Otherwise, look for another cause. And if the condition of the patient is severe, then initially we must focus on stabilizing the vitals. Then after that, only we shall focus on towards moving to the specific diagnosis of the cause. The important questions that we have to ask in history include timing, quality, effect of position, associated features, effect of dyspnea on lifestyle. So these are the important questions that are not to be missed while asking history taking to a patient with dyspnea. And the red flag pointers, which specifically points to the fatal and treatable causes, if present, requires special attention because they help to rule out the potentially fatal condition or rule in the potentially fatal condition which might cause dyspnea. So thank you. Hope you enjoyed it. Please do comment